Good evening. You're all welcome. I welcome you all this evening for this webinar series. It is a bi-monthly event which usually comes up every second Wednesday and third Wednesday of each month. And thank you for joining us today for this all important webinar. I want to also encourage you to register for the upcoming AFRH conference, which is coming up in Lagos in September 2025. Don't miss out on the golden opportunity to register for the 15th AFRH Annual International Conference, Lagos. Early bird will end on the 30th of June 2025. So use this golden opportunity to register and enjoy the early bird registration. The annual conference is coming up on the 24th to 26th September 2025 in Lagos. And don't forget to secure your spot. And also don't forget to follow us on our social media handles, Twitter, Instagram, and Facebook. Follow us on Instagram, Facebook, and Twitter, and register for your conference. Thank you once again, and good evening. If you're joining us, you're right on time, and we are here today to speak, to talk about a topic that has been coming up in most of our conferences and in our clinics as we run our day-to-day activities. This webinar series is going to be an in-depth exploration on egg, sperm, and embryo donation, the ethical and medical consideration. Even as we participate in this webinar today, we have our very all-important barrister who is going to take us on the topic today, Barrister Halita Mafo Adekunle Esquire. She obtained a master's degree in insolvency law from the University of Pretoria, South Africa, a postgraduate diploma in insolvency law from Continuing Education University of Pretoria, and an LLB from the University of Abuja, and was admitted as an attorney of the Supreme Court of Nigeria in 2005. She also became a lead internal auditor after being certified by the Standard Organization of Nigeria on the ISO 9001, 2025 Quality Management System, etc. Barrister Halita Adekunle Esquire is an attorney, a mediator, a seasoned company secretary / administrator, a medical legal consultant, and trainee on various aspects of medical law and practice. Is also a lead and internal auditor of the Quality Control Management System Standard, etc. She recently attended the mandatory certification program of the Institute of Chartered Secretaries of Nigeria, ICSAN, and is on her way to becoming a chartered secretary after the fulfillment of all requirements. She is a corporate attorney that has acquired 20 years of experience in the field of corporate, commercial, and medical law and practice. She has also acquired certificate courses from the Institute of Directors, IOD, Employee Assistant Professionals Association, the African Management Initiative, AMI, South Africa / Kenya, etc. She is a member of the Nigerian Bar Association, the Association for Fertility and Reproductive Health, the AFRH Legal Legislative Committee, an associate of the Institute of Medical and Health Law, associated Associate of the Business Recovery Insolvency Practitioner Association, and a member of the Financial Reporting Council of Nigeria, etc. With her years of experience working in hospitals, she has acquired in-depth knowledge and skills in handling all matters regarding medical law and practice, corporate governance, corporate secretaryship, corporate and commercial matters, board and top management matters, medical legal training, employee assistance matters, preparation of agreement, debt recovery, company restructuring, etc. She is currently the group lead head legal advisor of the NISA Medical Group, a medical legal consultant and trainee in various aspects of medical law and practice, and how to avoid negligent actions. She's happily married with 3 children. I now welcome you to the floor as you give us your knowledge on egg, sperm, and embryo donation, the ethical and medical consideration. Thank you for listening and thank you. Welcome, Barrister Halita Adekunle. Thank you.
Good evening, everyone. Hope you had a wonderful holiday. Please, I'll just quickly, I've tried to share my slides. I'll just quickly perfect it.
Sorry, before she shares her slide, feel free if you have any questions to use the Q&A button and send your questions. At the end of her presentation, we'll take the questions from there. So feel free to use the Q&A button to send your questions. Thank you.
Thank you, Mrs. Rifkatu. So today we'll be looking at egg, sperm, and embryo donations. And we'll also be looking at the ethical, legal, and medical considerations regarding these subtopics. Our outline include an overview of assisted reproductive technology and classification, the legal framework. And for each of the subtopics, we'll be looking at the indications, the types, the procedure, the medical, ethical, and legal considerations. I also chipped in who are the pros and cons of known and anonymous donors, and of course, the challenges being faced with some of these issues and the recommendations. So what is assisted reproductive technology? I know it's not new to almost all of us on this group, but the main thing here is it aids couples that are not able to conceive naturally, except with medical assistance. It includes the usage of medical and scientific technology to reproduce human gametes and embryo. And at the end of the day, the main objective is to get a term pregnancy and to deliver a child. So there are different types of assisted reproductive techniques. We have the in vitro fertilization, IVF, which is very common. We have egg donation, sperm donation, embryo transfer, surrogacy, cryopreservation, and just to mention a few. I regard this as some of the ART-related regulations because one way or the other, we have to make use of some of these regulations in our practice. And these regulations include the National Health Act 2014, the 1999 Constitution, the Criminal Code, the Medical and Dental Practitioners Act, the Code of Medical Ethics, Violence Against Persons Prohibition Act, Trafficking in Persons Prohibition Law Enforcement and Administration Act, the Nursing and Midwifery Council Registration etc. Act, the AFRH Regulations and Guidelines, revised guidelines for good practice in IVF laboratories by the created by the European Society of Human Reproduction and Embryology, comprehensive guidance for human embryology, andrology, and endocrinology laboratories by ASRM, that's the American Society for Reproductive Medicine, the Hug and Association of Clinical Embryologists 2012. There are three aspects of law that applies to ART practice. They include the law of contract, the law of agency, and the tort of negligence. How does this apply to us? Now, I'll start with the law of contract. So there are four elements of every contract. There must be offer, there must be acceptance, there must be consideration, and there must be a subject matter. So when a patient walks in to see a doctor or comes into the clinic to access care, the patient has basically made an offer. So when the front desk officers start the process of taking your EMR number and posting you, all that process is the acceptance process. And then by the time the patient is told, go and get clearance, whether you are an insurance patient or you are a private paying patient, the patient goes to pay cash, all that aspect is the consideration. And then when the patient goes in to see the doctor, what happens there is they discuss the subject matter. So basically, when a patient walks in, from the time the patient walks in, makes the offer and sees the doctor, collects the treatment and goes, there is a contract that has already kickstarted or already exists. And once there is a contract, there could be a breach or a deviation from some of these issues, and there may be a damage or an injury to the patient, and of course, the patient will be looking for damages. The second aspect of law that applies to ART practice is the law of agency. So who is an agent? An agent is a person that acts on behalf of a principal to see a third party. In this case, the agent is the doctor. When I make mention of doctor here, I mean every healthcare practitioner that is involved in this process. And then the principal is the hospital or the employee or employer. And then the third party that is saying is actually the patient. Now, because of the relationship that exists between an agent and his principal, there is a principle known as vicarious liability, which provides that the principal will always be vicariously liable for the actions of the agent. He cannot excuse himself from it because the agent is acting in his stead. I've put here a case of Dixon Ibokwe versus the University College Hospital Board of Management. In that case, Dr. Dixon's wife went to give birth. And after giving birth, although she had some mental challenges, so after giving birth, she was kept on the 4th floor. And from the 4th floor, she fell and she died. And Dr. Dixon sued the hospital. But in court, the hospital were of the view that the doctors and nurses that did not think to restrain her or put in measures to prevent her from harming herself are the ones to be sued. But the court said no. What is to happen here is that those doctors and nurses were actually your agents, and as such, you will be liable for their actions with regards to the principle of vicarious liability. The third aspect is the tort of negligence. Usually, when there is a negligent action, the criminal code provisions does not punish for negligent actions because negligence occurs because sometimes there may be errors, especially when you are carrying out your duties. So it doesn't. But when there's cases of murder, or when there's a case of murder, or when someone dies, passes away, then of course, Section 4 of the 1999 Constitution kicks in with regards to fundamental human rights, and especially the right to life. Chapter 4, sorry, of the 1999 Constitution with regards to fundamental human rights, and most especially the right to life. And as such, it will be looked at that you took the life, your actions led to the loss of life of someone, and of course you have to be punished. But because negligence most times may be seen as errors or may be seen as intentional. In cases where there are errors or in cases where it's a case of negligence, what will happen is you'll be charged for manslaughter. So with regards to negligence, there are 4 aspects we should look at. We have the duty of care. Everybody has a duty of care in the exercise of his duty. We have a breach of that duty of care. That's when you deviate from the pathway that you're supposed to follow when carrying out your duty. And then we may have damage to the person, which is an injury. And then, of course, the person will look for damages. So now with regards to egg donation, as I said, each subtopic will look at the indications, the types, the procedure, the ethical, legal, and medical considerations. I'm going to start with egg donation. So it's a process whereby a fertile woman donates an egg or oocyte to another woman to help her conceive. So what are the indications for this? Premature ovarian failure, ovarian agenesis, early menopause, surgical removal of bilateral ovaries, radiotherapy or chemotherapy for ovarian cancer, advanced maternal age, post-menopausal patients, need to avoid a congenital anomaly, and so on and so forth. There are 2 types of egg donation. We have the traditional egg donation and the shared egg donation. So what I've tried to do here is to try and just highlight certain things for our understanding. So for the traditional egg donation, it includes one set of intending parent or a single intending parent. It includes 1 egg donor. A single egg retriever usually yields the number of eggs required. And of course, there's full control over the eggs and the resulting embryos. For shared egg donation, you have more than 1 intending parents or single intending parents. You still have 1 egg donor, but there is a shared cost for the egg retrieval procedure. Of course, you don't have full control over the number of eggs that has been produced. And of course, there must be separate legal agreements for each intending parent or single intending parent. The procedure for egg donation include the registration and provision of identifiable or non-identifiable information, signing of legal agreements and consent forms. This is necessary to confirm anonymity, parental rights, compensation to be paid, extensive medical screening and thorough selection process, administration of medication to stop normal menstrual cycle, administration of medication for hyperstimulation or to stimulate the ovaries to produce eggs, performance of transvaginal ovarian aspiration to remove eggs, psychological counseling, which is very important, and rest. Some of the medical considerations include the age of the egg donor, the criteria for selection of the egg donor, and most times these criteria are set based on discussions with the intending parents as to what they want. Adequate medical lifestyle, family history, sexual history, donation history, etc. is to be given. Counseling on the risk and likely complications is also to be given. Ascertaining psychological and emotional readiness and adequate psychological evaluation and taking of psychological history. Physical examination, if any. Medical screening, this is very important. And then radiological testing. Some of the ethical considerations include preservation of anonymity vis-a-vis the rights of the offsprings to know their identity. With time, throughout this lecture, we'll realize that anonymity is gradually being phased out with social media and mostly with social media and genetic knowledge or technology, genetic technologies. But I'm sure as I go through the presentation, we'll see that. Other ethical considerations include the rights of the egg donor, counseling and consent, financial compensation of an egg donor vis-a-vis the possibility of exploitation, participating voluntarily, free from any coercion or undue influence, clearly defining parental rights and responsibilities towards the offspring conceived, setting criteria for choosing an egg donor with certain traits vis-a-vis pre-implantation genetic testing, vis-a-vis genetic profile, and promotion of modern eugenic movement. So what is eugenic? Eugenic is basically the use of selective breeding to improve the human race, which one way or the other has been looked as it causes inequality and injustice because it's a particular breed that is usually wanted with regards to the child, the offspring. So how many times can an egg donor donate vis-a-vis the likelihood of consanguinity among egg donor offsprings, and then the handling of surplus or stored cryopreserved gametes in case of death or divorce. Some of the legal considerations include clear legal documentation on the egg donation process and procedures, written and signed consents, including withdrawal of consent, confidentiality vis-a-vis anonymity, proper medical documentation of the donation process, non-discrimination, clear agreements detailing parental relinquishment, details on the birth certificate, no accountability for parental legal or financial responsibility. Other legal considerations include disputes on the rights of the offsprings to know their identity, which is what is gradually happening right now, clear legal documentation and the handling of surplus, stored, or cryopreserved gametes. Now we'll move on to sperm donation. And this is a process whereby a man donates his sperm either directly to the recipients or to the sperm bank with the intention that the sperm be used to fertilize a woman so that she can get pregnant. Some of the indications include single women may request for it, male factor infertility like azoospermia, severe oligospermia, or other sperm or seminal fluid abnormalities, male carrier with hereditary diseases. There are different types of sperm donation. We have intrauterine insemination, intracervical insemination, intracytoplasmic sperm injection, in vitro fertilization stroke, intracytoplasmic sperm injection. The procedure for sperm donation, just as I mentioned with egg donation, it also includes the registration, so provision of identifiable or non-identifiable information, assurance of good health status with no genetic abnormality, signing of legal agreements and consent form, confirming anonymity, no parental rights to compensate, and also the compensation to be paid, extensive medical screening through selection process, production of fresh semen samples in a private room, assessing the quality of the sample taking, storage of the sperm. Medical considerations, just as I've said with egg donation, of course, the age limit, the criteria for selection, adequate medical, lifestyle, sexual donation, and family history, to determine, most importantly, this is necessary to determine genetic or inherited diseases. Counseling on the risk and likely complications that may exist, getting an informed consent, which is also very important with the egg donor. Psychological and emotional readiness, adequate psychological evaluation and taking of psychological history, physical examination, medical screening. Some of the ethical considerations include preservation of anonymity vis-a-vis rights of the offsprings to know their identity, rights and responsibility of the sperm donor, counseling and informed consent, financial compensation vis-a-vis prevention of exploitation, just as I mentioned with the egg donors, the rights and responsibility of the intending parents, and for them to understand that the likelihood of success, there may be need for multiple treatment, there's a likelihood of diseases or abnormalities, and their responsibilities towards the offspring. Setting criteria for choosing a sperm donor with certain traits vis-a-vis the usage of pre-implantation genetic testing, vis-a-vis genetic profiling, and promotion of modern eugenics movement. Some of the legal considerations include clear legal documentation on the sperm and donation process and procedure, written and signed informed consent, including withdrawal of consent, which also applies to egg donors too, confidentiality vis-a-vis anonymity, proper medical documentation of the donation process, non-discrimination, no legal or financial responsibility, clear agreements regarding relinquishing parenthood, donors' inability to assert parental rights in the future, donors' inability to be named on the birth certificate, and the donor too cannot be held accountable for parental duties. Ethical consideration continues as follows. How many times, you also have to look at how many times a sperm donor can donate at a time, vis-a-vis the need to prevent accidental consanguinity or incest among donor offspring, handling of surplus or stored donors in case of death or divorce. It may interest us to know that in France, Germany, and Sweden, there is a prohibition by their laws for the usage of cryopreserved diseased sperm, but in the UK, written consent suffices. Then we have the post-mortem sperm retrieval, vis-a-vis the need for consent, vis-a-vis the designation of the retrieved sperm as property of the deceased. Other legal considerations include clear legal documentation and the handling of surplus, stored, or cryopreserved garments. Now we'll move on to embryo donation, and I hope we're all enjoying the presentation so far. And for embryo donation, it's just when an individual or couple donates surplus embryos from their own IVF cycle when their family is complete. This occurs when a successful IVF patient is not disposed to destroying or storing their embryos forever. So what are the indications? Surplus embryos and unwillingness to discard, store, or cryopreserve, couples with male and or female factor infertility, single parents with infertility, secondary infertility, unwillingness to pass down a medical condition or genetic disorder. There are two types of embryo donation. We have the non-identified, as modified by the American Society for Reproductive Medicine. It was formerly called anonymous, but now it's called non-identified. And then we have the open ID. So some things to note, some highlights for the open ID includes: one, the donor may want to be notified of an ongoing pregnancy or live birth. He may want to know the geographical location of the recipients. He may want to know, or the embryo, the couple or individual may want to have phone calls or photos with the offsprings and to be contacted for medical conditions, if any. The procedure include embryo selection, preparation of the endometrium of the recipient, embryo thawing, embryo transfer or direct placement of the embryo in the uterus for implantation and development. 10 days after the embryo transfer, the pregnancy test is done to confirm if the implantation has been successful. If yes, the first ultrasound is done 2 weeks later to check on the progress and location of the pregnancy. If a positive pregnancy, patient continues with the pregnancy. The medical considerations include the age limit for both the egg donor and the sperm donor, the embryo donor medical and psychological screening, psychological and emotional readiness, history of genetic disorder or illnesses, detailed medical lifestyle, sexual donation, family history. If the couple has a child, the child must be a year before any donation is made. Frozen embryos must be less than 10 years old and stored in IVF unit. Some of the ethical considerations include counseling on the implications and informed consent, anonymity and provision of non-identifiable information vis-a-vis the right of the offspring to request for identifiable information, the fate of the surplus to cryopreserved embryos, usage of embryos for research, right to withdraw consent on or before the embryo transfer process, determining the number of embryos to be transferred at a time, selective reduction in multiple pregnancy vis-a-vis the termination of fetal life and abortion, which is illegal in Nigeria. And then some of the legal considerations include the legal documentation authorizing the embryo donation and specifying legal parenthood, written and signed informed consent, including withdrawal of consent, proper medical documentation of the donation process, which also applies for the egg and sperm donation process, donor financial compensation, confidentiality vis-a-vis anonymity, documented and reliable addresses for follow-up medical tests, clear guidelines on the number of embryos to be transferred at a time. Other ethical considerations include setting criteria for choosing an embryo donor, and I've mentioned it before regarding the eugenic movements, issues of consanguinity or incest, usage of PGT, pre-implantation genetic testing for sex selection, handling of surplus, stored or cryopreserved garments, and non-consensual disposure of embryos. So some of the legal considerations include the proper documentation of the donation process, clear agreements regarding relinquishing parenthood, which I've mentioned before, clear legal documentation on the handling of surplus, stored or cryopreserved garments, and then the likelihood of paternity disputes, dispute over the fate of cryopreserved embryos, and dispute between the ART practitioners and the patient, and custody disputes. So these are just disputes that may arise, which we need to look out for. So in this presentation, I've gone ahead to bring out the pros and cons of anonymous donors and known donors. So for anonymous donors, the pros include peace of mind for the parents, less interference on parental decisions. It allows parents to maintain the issue of infertility as a private matter, less risk of legal dispute. Studies show that anonymity or non-disclosure does not harm the children psychologically. But the cons include provision of only non-identifiable information about the donor, inability to communicate in the future. Even though anonymous, new genetic testing technology can disclose the identity of the donor, risk of identity suits, more expensive, and the offspring may be subject to social or psychological disorders. For the known donors, the pros include trust and comfort, transparency and honesty. You have more information about the donor's background. You have more details about the medical, lifestyle, family history. It's less expensive. Genetic connection to the child. The donor conceived child can know their identity and can make future contacts. The donor, parents and child can have a healthy relationship, but it comes with its own challenges. And some of them include conflicts over parenting decisions, the generation of family bond and relationship, creation of a complex relationship, ethical concerns, i.e., such as the donor's role in the child's life. The donor may feel pressure to interface with the child, and then the risk of legal dispute. So now, what are some of the medical, ethical, and legal challenges? I know this presentation was only targeted at medical and ethical considerations, but I went ahead to include some of the legal issues so that we can all be aware of it. One of them include lack of regulations, lack of information regarding the laws and requirements of other jurisdictions. So when I talk about other jurisdictions, I'm also talking about countries outside Nigeria. Scanty or no agreements, not getting informed consent, and donors not having full understanding of the procedure, including the associated risk before proceeding with the donation. I think this is very important. Donors should be educated so that you can get their informed consent. Failure to abide by the minimum age limit, not clearly defining who has parental rights and responsibilities. There is a general assumption that once you're a donor, you don't, but it's good if it is documented as to who has parental rights and responsibilities. Not understanding the implication of using a known donor. No database of donors vis-a-vis the autonomy of the offspring to know their identity, and then the fact that we now have modern genetic technologies and social media that also helps them to maneuver their way to find that out. No clear regulations on limiting the number of donor offsprings from a sperm donor. So I try to give what currently applies in some countries based on my research. In China, it's 5. In US, there are no laws, but the American Society for Reproductive Medicine recommended 25 children per a population of 800 for a single donor. The UK HEFA recommended 10 vis-a-vis, and we will have to look at all these things vis-a-vis the issue of consanguinity or incest. I've talked about the issue of eugenics and the fact that it promotes inequality and injustice. There are no clear research on whether infants born via IVF are at increased risk for rare epigenetic and other abnormalities. No clear agreements on the fate and handling of cryopreserved embryos. And then, of course, we have no clear provisions on ART services to single parents vis-a-vis the need to create a family unit. And then we also have other challenges such as who owns the stored garments or embryos, especially with the death of one person in the case of divorce. Funding of ART process vis-a-vis affordability, it's quite expensive. Possible exploitation of the need and hope of donors because most of them are not even ready to understand the implications. All they are going in for is for the money. Access of ART to postmenopausal women, embryo mix-up, and custody of offsprings. We're gradually getting to the end of the presentation, and here I'm going to present my own, some recommendations, which are my own opinion as to how some of these things can be addressed. Creation of a comprehensive regulation that will include gamete and embryo donation processes. Understanding the laws and requirements in other jurisdictions with regards to an ART, with ART and usage of donor egg or sperm. Creation of a database of gamete donors to be shared amongst all registered clinics. Creation of an apt donor agreement that will clearly define anonymity or otherwise, including the rights of the donor to the gametes, embryo, resulting children, parental rights, getting informed consent, shared disposition or storage or discarding of unused gametes, etc. That's basically, I'm trying to list out what the donor agreement should cover. Creating clear policies on regulations on the number of times a sperm donor can donate sperms, including placing limitations on the number of children a sperm donor can produce. Understanding the implication of using a known donor and clearly defining roles and responsibilities in a known donor agreement. I think this is also very important. Creation of an ethics committee in every clinic to deliberate on ethical issues that may be raised. Continuous improvement on technologies that can assist women with, that's cancer patients with fertility preservation. In-depth medical screening aimed at minimizing the risk of infection or genetic abnormalities. Awareness on the fact that modern genetic technology and social media is gradually breaking the barrier of anonymity vis-a-vis the child's autonomy to know their identity. Open ID system, so establishing guidelines for disclosure of donor origin, including age of donor or age of disclosure to the offspring. So this was a table I found during my research, and it basically tried to highlight those countries that that allow for ID release or non ID release. So like, for example, in the United Kingdom, for single women, yes. For heterosexual couples, yes. And the only is only ID release. So for United States, yes, yes, they do both. Sweden, yes. Germany, yes, although not all clinics offer this. I think I'll take us down to Poland. For single women, no. Heterosexual couples, yes, and they only do non-ID release. For Spain, yes, yes, but they only do non-ID release. These are some of my references that I've used. I would like to appreciate God Almighty, the AFRH and the AFRH Training Committee for the opportunity. Hope I was able to meet your expectation. I would also like to appreciate my CEO, Dr. Ibrahim Wada OON, my GMD, Dr. Musa Shaibu, and my MD, Dr. Nonso Gwefi, for giving me the platform to improve my skill, expertise, and experience acquired with regards to ART practices, my family, and everyone who has contributed one way or the other to the success of this presentation. So nothing is impossible. The word itself says, I am possible. So I think we should go with that. And thank you.
Wow. Wow. Thank you very much for that in-depth presentation. It was really
Thank
an eye-opener on things that we did not know about egg donor and sperm donor with embryo donation. I think most of us that are here on this webinar must have gotten some insight and ready to put it into practice. Thank you, Barrister Halita Adekunle, for that wonderful presentation.
Thank you, ma.
Kudos to you.
Thank you, ma.
Yeah. The Q&A question, we have only one questions there. Professor Christian Markwe, can you say something? Oh, you're still on transit. Before we open the Q&A,
Um, Thank you,
sir.
everyone. Sorry that you don't have my video on. I hope I'm audible. That was a
Yeah,
very
we can hear
excellent
you.
presentation. And we want to say thank you for this presentation. I have learned a lot from this presentation, and the fantastic job you did also enlighten us what happens around the world. I will now hand over to you so we can attend to questions, and I hope we'll be able to answer all the questions our participants have. Thank you, and over to you, ma'am.
Thank you, sir.
Thank you. We only have one questions in the Q&A. The the first question by Joseph Akintojoye. Do you think egg donors should be insured? How can we get policy from insurance companies in Nigeria? So maybe you just go ahead and answer this question, and let's so that Joseph will hear and others too.
Okay, ma. Okay, can I stop sharing my screen, or can I
Very well.
proceed to
If you
stop?
don't,
Okay. So I'll just say my own view, and I'll in a way give um I'll give a view that I've also noted from some of my research. So what happens with regards to egg donors is that they tend to put them under health insurance. So it's more or less like a compensation to them. So after the donation process, because of the fact that there may be some complications like OHSS, so they keep them, they give them, put them under health insurance for like a year. So that
Okay.
is the only form of insurance that I've been able to see that happens. I don't know, I'm not sure if we practice that in Nigeria, but in other countries, it happens like that.
All right. Thank you. Can you give us a little more on the insurance? What is happening in NISA Premier, if I may take you back, on the insurance for egg donor? I know some clinic use these egg donors and just immediately after egg collection, they dump them and don't even care for their well-being. So maybe you expatiate more and give us an experience of what you people are doing in NISA Premier. Thank you, ma.
Okay, ma. So what happens with this egg donor health insurance? So it's not like per se NISA practices it. It's just what I've read from other countries. And I think it's something we can take a look at. The organization can take a look at and see if it can be imbibed by almost all clinics. They get them the NHIS health insurance program. So they register them under the scheme. So there is a health insurance scheme known as gift ship. So it's not that expensive. I know the price was increased from 15,000 to 30, I think it's 36,000 per year. So that way,
Okay.
you just monitor the health of the egg donor during that 1 year period. It's more or less like an incentive to the health donor, which is being practiced by some countries. Thank you.
All right. Thank you for that. There is um, Olawole Shitu wants to give us a small insight on the law about compensation regarding embryo donation. Or can you give us some laws that talk about compensation regarding embryo donation? If you have any,
Oh,
ma.
okay, ma. So, like
Yes.
For the National Health Act 2014, with regards to dealing with garments, what the act says that is there should be um, reasonable compensation. So, reasonable compensation could be compensation for inconvenience, compensation. So the act wasn't clear as to what reasonable compensation covers. So it could be for inconvenience, it could be for your transport and things like that. But there is no law in Nigeria that categorically says you must pay an egg donor. But what the National Health Act, as I said, only provides is reasonable compensation should be given to the person. Otherwise, payment for garment is not allowed. Thank you.
All right. All right. Thank you. The second question we have on the Q&A from an anonymous attendee said, in a situation where a patient previously underwent IUI with sperm donor, resulting in a successful pregnancy, and returns years later requesting that same donor, but is informed that the donor sperm was not stored or is no longer available, what measures can a clinic take to prevent such ethical concerns from arising in the future?
Okay, Ma, so if I hear you
Barrister,
correctly,
yes, ma'am.
okay, Ma, so if I understand what you've said, a donor made use of a
Yes.
particular, an intending parent made use of a particular egg, sperm donor, and came back years later for the same sperm donor.
Same.
So I
Yeah.
think
Yeah.
what comes to play here is what you people have agreed upon. Things have to be clearly documented. So if a sperm donor, if an intending parent comes to you to start a process And at that time, he or they present, or she presents, if it's a single parent, or he present, they inform you that, okay, fine, this pregnancy is going to be our first child, and we're going to come back maybe in the next 4 or 5 years to come and get the second one and want to use this same sperm donor. Then that should be clearly documented. There are processes for cryopreservation of gametes. There are fees to be paid for cryopreservation. That should be sorted out in an agreement, the necessary payments made, and I feel that's the measure the clinics should take. Thank you.
Yeah, thank you. If he doesn't pay for cryopreservation, at least he has no legal right.
You're
Okay,
right.
from Olu Busola Jeremiah Yusuf, he said, has there been any litigation in Nigeria on egg donation? And if yes, how it was handled? That's the number one question. The second question is, how do clinics protect themselves from donor litigation in case it arises in future?
Okay, so far I've not seen any litigation on um, any donor issues or anything like that. I've not read any case on that, but I feel clinics can protect themselves with their documentation. That's the most important thing. Your documentation must be apt. Your documentation must be concise. Your documentation you must explain what you are documenting to the patient so that they will understand and you get an informed consent from them. What happens is when patients feel they are not carried along, they don't understand the process, that's when issues arise. Let me be honest. But by the time you've explained it to them, they fully understand it, you get it documented. Even on the documentation, you clearly write there that the above was fully explained to the patient, and it was explained in the English language or whatever language that the person, if it's Hausa or Basange, and the person seems to understand it, the person understood it clearly, and as such, I append my signature, something like that. So most importantly, I also feel clinics should try by all means to always involve a lawyer. Times have changed when clinics were on their own, doing their own things, making their own mistakes. But we should understand that, as I said, times are changing, regulations are coming up now with regards to ART practices. And because of that, we have to be careful. We must have our legal backing. Thank you, ma'am.
Thank you very much. The next question says, is it ethical to cryopreserve sperm or oocytes of a donor without consent from this donor? Tough one, eh?
If I get you right, is it ethical to
Yeah, it's ethical.
cryopreserve
Sperm or oocytes.
sperm from a donor without consent?
Yes, from the
For me,
donor, not.
I feel that involves a lot of ethical issues because it's unethical, and legal issues also, because you must seek consent of the egg donor. And that's why if we look at the question that was asked earlier regarding an intending parent saying, I want to make use of the same egg donor, documenting it, explaining
Yes,
to the donor that this your sperms will be cryopreserved
use.
for this particular, for the patient we are using it for. I think that's the best route.
All right, thank you very much for that question, for answering those questions for me, ma'am. There's an attendee in the conference. Okay, we have still one. Can donated embryos also be termed embryo adoption? If yes, how does that compare to adoptions law in Nigeria? That's comparing embryo donations and adoptions law in Nigeria. How can you compare that from
Mm.
Mrs. Abiola Adewusi?
Okay, so I'll give my own view regarding this. So we don't have, how will I put it? you can't
Compare.
term embryo. The question was what again, ma? Sorry. Is embryo
Okay,
donation?
can embryo donated with term embryo adoption? That's the first thing. Then, if yes, how does that compare to adoption laws in Nigeria? That's the adoption laws we have, and the
Okay,
embryo.
so my own views are that embryo donation cannot be termed as embryo as adoption. That's my own view,
Oh,
because the
okay.
person, the what you are donating is, of course, is a life, but it may survive or it may not. And with regards to the adoption laws, where the child must have reached a certain age requirement before you can begin the adoption process. So it cannot.
All right.
Thank you.
Thank you. I would like to give, thank you. Let me put you on hold first. I would like to give Dr. Olaore Shitu an opportunity to be able to say something about the compensation regarding embryos. What are those things? Dr. Shitu, are you online? It's not. Dr. Olawale Shitu, are you online? No, I think he's not online. So I think we're done with our questions, all that have been said. So it's now time for us. Any last word, Barrister Halita Adekunle, before we draw the curtains? Since we have some few more minutes before we draw the curtains. Any last words? Barrister Halita.
None from me, ma.
All right. From a comment session by Odinga, she said, we don't have any laws regarding embryo sharing stroke donation yet. We presently extended the provision of the National Health Act regarding blood donation, but this is not a legally recognized practice. Just to add to that. And then the last question that we have, how can we have donor database to limit outside donation for a particular donor? Because these donors run from one clinic to the other, giving different IDs and donating eggs. So,
Yeah. I feel that's actually a challenge, because having a donor
database.
database both for egg and sperm donation is the key to go. I feel with the Nigeria is gradually changing with regards to the coming up of the proposed regulations and things like that. And I think once that is created, it will go a long way in assisting us. Creating a database is not only for it does not only help the clinics, it also helps the donors, because at least for their health, they're able to know that there should be a limit to the number of times you donate at a time. I know some of us in AFRH have tried to create some of these platforms, or may have a platform where they are able to regulate some of these, regulate and have a database of donors that come through them. I'm not sure, but I think Mrs. Biola, the VP of AFRH, has something like this, because I know we once discussed that. So, but whatever the case may be, I believe a lot of improvement can be made. Um, there was something I suggested. I don't know if it's possible with the way Nigeria is, but we can actually, the clinics can actually have a database, where a shared database of all these donors. So, for example, if someone comes to NISA and maybe your ID is imputed, I don't know what can be imputed there. Someone in Dida or Div or someone in Lagos can actually see that that donor was there last week, something like that. I don't know how that can happen. These are just my own views or suggestions regarding it, but I know something can be created no matter how small it is, and we can build up from there.
All right. Thank you very much, Barrister Halita,
Thank you,
for
ma'am.
that wonderful exposition. Before we draw the curtains, I would like to encourage each and every one of us to register for the upcoming AFRH conference, which is coming up in September in Lagos. Take advantage of the early birds and register so that you secure your spot in the AFRF conference. And do keep your calendar open for our bi-monthly webinar series that give us insight and clarity on what we do as AFRH members. Thank you very much, my barrister,
Thank you, ma'am.
and thank you for that wonderful presentations. God bless you.
Thank you.
And thank you,
Amen, ma'am.
everyone,
God bless
every
you too.
participant. Thank you very much for tuning in today for this wonderful webinar. Hope to see you again in the next scheduled webinar. And don't forget to follow us on Facebook, Twitter, and Instagram for the webinar. Thank you very much.
Thank you, ma'am.
Okay, let me give Professor Christian Mago is back online. So give your final word before we close. Thank you very much, sir. Thank you. Professor
All right.
Christian.
Thank you,
you, sir.
everyone. I just want to thank our speaker today for an excellent lecture, and I also want to thank all the participants. And I wish you all a very nice evening. And we look forward to seeing you during our next presentation. Thank you, everyone.
Thank you, everyone, and have a wonderful evening.